Okay. Well, I think we've got some people still trickling in. So I'll go ahead and just start with some of our intro and announcements things before we get to our presentation. Welcome everyone to this session of the 2023 Culture of Data Conference. Thanks for being here. I'm Julia Simhai. My pronouns are she, her, hers, and I'll be moderating this session. We also have Peggy, who is managing the Zoom. Peggy's name shows a COD breakout room 4. So if you have any issues or need help with our Zoom tech, please feel free to chat that COD breakout room 4 to get some support. If you have questions, you'll be able to unmute. We also have the chat box that we can use for this session if you need anything or want to ask questions of the presenters. If you're comfortable doing so, please add your pronouns to your Zoom name. You can click on the 3 dots on your video in the corner of your square and select rename, and then you can edit in there. I'm going to hand us first to our sponsor of this session. This was generously sponsored by the Colorado Department of Public Safety's Office of Research and Statistics. So we are grateful for their contributions to the conference, and I'm pleased to introduce Allison Rosenthal from their office to share a few words.
Thanks, Julia. The Office of Research and Statistics is really proud to sponsor this Culture of Data breakout session. The office is a part of the Colorado Department of Public Safety, and we provide decision makers and the public at large with data on criminal justice in Colorado. We believe our data could be used to help break down silos between public health and public safety. And we welcome you to go to our website. It's ors.colorado.gov. And I can put that in chat too. And you can take a look at our published reports and dashboards. We have original data sources and secondary research that we highlight on our website. And here are just some of the topics you can find on our website that we provide data on. We have data on criminal justice contacts with students, impaired driving, the impacts of marijuana legalization, and racial disparities in criminal justice decision points. We are also in the beginning stages of collecting data on all law enforcement contacts with civilians, and this will be a key data source to facilitate increased transparency in law enforcement operations. Our first report will be published on this data source, and we'll release it this year. Our office also staffs the Colorado Commission on Criminal and Juvenile Justice, whose mission is to enhance public safety and justice through evidence-based analysis, resulting in legislative and policy recommendations. Commission meetings are open to the public, and we welcome you your interest in criminal justice reform in Colorado. You can go to that website. It's ccjj.colorado.gov to find out more information. Thank you all.
Okay, thanks, Allison, and thanks again to the office for sponsoring and for the great work that you're doing. So due to a last-minute scheduling change, unfortunately, one of our presenters for the session couldn't make it. But we still have one great, that's going to be a great one. So glad you're here. Our theme for this session is emerging trends in substance use monitoring, and the presentation that we're going to hear is a great example of why this conference exists, talking about ways that an organization has changed data collection to keep up with trends and get data that's not available in the past to identify and track progress toward addressing health issues in communities. This presentation, as you can see, is called Menthol Flavor, Lost in the Data, and we have a great crew of Terry, Tracy, Aubrey, and Tiffany here to present. So I will hand it over to them, and we will have time at the end for Q&A. So feel free to drop things in the chat or hold your questions, and we'll have plenty of time to discuss since we just have one presentation in this session. So take it away, team.
Thank you. Next slide, please. Hi, everyone. I'm Tiffany Schommer. I am the program manager for the Ambulatory Nicotine Cessation program at the University of Colorado in CU Medicine. I have a background in public health and population management. I've been at the university for about 9.5 years and started this program back in 2018.
Hi all, my name is Aubrey Bush and I'm a tobacco cessation specialist in the Ambulatory Nicotine Cessation program. With Tiffany, I've been at the university for over 5 years at this point, and I have a master's in public health.
Next slide. As I mentioned, we developed this program back in 2018 as a way to help our primary care patients quit nicotine. It is a program that is funded by Medicaid through HCPF, and it is zero cost to patients. Although it is a Medicaid program, we do see patients from all payers. We do not charge patients or insurances, so it is no cost to patients whatsoever in an effort to remove all barriers to care. Right now, we serve 26 primary care and specialty clinics in the Denver metro area, from Lone Tree to the south to Boulder to the north. And that comprises roughly 18,000 current nicotine users. Clearly, they're not all ready to quit nicotine at this time, but that is the pool that we make up. So it's a very large need, and that was why we developed this program. Next slide, please.
Good afternoon, everyone. I'm Dr. Terry Richardson. I'm the Vice Chair of the Colorado Black Health Collaborative and a retired internist. CBHC was formed in 2008, and our mission is to achieve health equity in Colorado's Black community. Tracy?
Yes, and I'm Tracy Gilford, also with the Colorado Black Health Collaborative. I've been with the organization for a while, working specifically on tackling menthol in the Black community project as project coordinator.
Next slide. So we want us to start out by telling you a little bit about the Tackling Menthol in the Black Community Project. It started in 2019 with a wonderful grant from CTTS, and our project goals were really to increase the understanding of the harmful effects of menthol and flavored products in the African American Black community. And as you see depicted here, these are some of the ads that were utilized to entice Black smokers to smoke menthol, and even has transitioned over to the vape world. Next slide. So how did this all get started? In a sense, I'm going to tell you that we're going to look at some data that started way back in the 1950s. There's a tobacco company, Brown and Williamson, who were famous for the Cool brand, who did a survey. And in 1953, they found that 5% of Blacks versus 2% of whites preferred menthol. And they said, oh my goodness, Blacks sure do love menthol, 5 versus 2. And they really seized the opportunity to capitalize on this small preference margin. They were already kind of marketing menthol cigarettes as, you know, a natural minty flavor, kind of similar to Vicks Vapor Rub. So certainly this was a healthier tobacco product. That's what they were selling. But this predatory marketing started. They enlisted scientists of all sorts, social scientists, sociologists, psychologists, and they were hired to engineer the product and create targeted marketing that would appeal to African Americans in this sense. It was not Blacks, but specifically African Americans. And CBHC talks about the M&Ms and M's because there was money, marketing, and manipulation that they utilized, that these tobacco companies utilized to addict African American smokers to menthol. And so they were putting profit before public health and people. And sure enough, their methods work because 80 to 90% of Black smokers across the nation use tobacco menthol products currently. On to the next slide. So I want to share a little bit about the tobacco metrics or smoking metrics here in Colorado. We always think about Colorado as a really healthy state. So we think we're better than the rest of the nation in everything. So certainly smoking in this clean air in the mountain, the Rocky Mountain air should be better. But before I share the data, I want to talk a little bit about the state tobacco education and prevention programs data sets that they use, the Healthy Kids Colorado survey, the BRFIS, most people know what that means, and then the TABS, the attitudes and tobacco and behaviors survey. And some of this data is utilized to come up with these sorts of graphs. This one's from CDC from 2020. And we all know that data always lags behind. We're in 2023, but this is kind of the current data that we have. And what it shows is that in Colorado, Blacks had the highest smoking rate at 23%. And actually, this is well above the national average, which was 15.5% for all US adults. And this is adult smokers. On to the next slide. And we were the only group that was showing an upward trend as the rest of the people were staying flat or going down. A few more metrics in Colorado. Our smoking increased substantially among the Black African-American population between 2001 and 2018. Again, they were the only group showing this trend. And we know that smoking among Black and African-Americans has now doubled that of white American adults. Unfortunately, 40% of the smoking among Black Coloradans occurs in the age of 18 to 29, so our young adults. And this is just as the tobacco companies intended. Get the smoker younger, they get addicted, and they go on into their death, and then they start over again. So it's like that never-ending cycle. Start with the young, they get old and die, and you start with the young. And among racial and ethnic groups here in Colorado, this is interesting too. You look at the numbers of 80 to 90% across the nation smoke menthol. In Colorado, Black African Americans are most likely to report ever using menthol flavored cigarettes at 72% versus 34% of whites who smoke. So Black people like menthol. So according to the tobacco companies. So let's move on to the next slide. And we were fortunate, we were able to participate in a survey or an assessment that was done by the School of Public Health. They want to look at the retail tobacco policy issues in Aurora. You know, Aurora is our neighbor right next to Denver. And for the Black population, Aurora is a significant spot for Black residents. You'll note here some of the things that were noted in this assessment was that 11.2% of Blacks in Aurora smoke cigarettes. That rate is lower than what we were reporting earlier. And part of that is due to the makeup of Blacks in Aurora. There tends to be more foreign or African-born Blacks in Aurora, so they tend to smoke less. That's not what we've seen in the data, but what we see when we're out and about, when we're in the streets and trying to see what's going on out there. They also know that 29% reported tobacco use by veterans in Aurora. And I think that's not a surprise to anyone. Higher rates of smoking have been noted in veterans. But what was also very interesting about this report, they talked about the difference between the north and the south part of Aurora. Aurora has vast land area, and the north tends to be lower income, more homelessness, etc., versus the south part of Aurora, not quite. I mean, the economic level is higher. And so they noted that the tobacco retail concentration was heavier in northern part of Aurora, particularly around East Colfax and 6th Avenue. And of course, there's a positive correlation between tobacco retailer density and smoking rates. On to the next slide. And this was done in 2021, 2022, and we were able to give some input on that. And I think everyone agrees, everyone that's in the tobacco space agrees that menthol is easier to start, very easy to get addicted to, and harder to quit. So CBHC took to the streets, and we were working with a number of health systems to find out how they're assessing smoking, how they are assessing their cessation rates and programs. And one thing that we found is that no one really could give us data on menthol use. And this was long before we ever met Tiffany, who we'll talk about, and Tiffany in her program, and we'll talk about that in a moment, but we just couldn't get the data. We also reviewed some of the quit line data. We know the quit line does a great job. I think on their website, they say our clinically proven methods help more than 450 people quit tobacco every day. I mean, that's impressive. We know that 70% of African Americans who smoke say they want to quit. And actually, they want to quit more than some other groups. And we actually found that Blacks, the data showed that Blacks are utilizing the quit line more, but we really couldn't easily get that outcome data. Did they quit? Did they relapse? What really happened there? We couldn't get that data, nor were we able to obtain menthol use data for quit line users. So menthol seemed to be lost in the data. So on to the next slide. And so here we have it, and I'm almost done with the section, but Dr. Cerise Hunt is one of our partners at the School of Public Health, and we were talking about what we could do around Black History Month. I think it was a year and a half or so ago, to educate people or make them aware of this issue around the targeted marketing in the Black community. And so this article was written, it appeared in the newsletter of the CU Anschutz Medical Campus. And Tiffany Schommer says, wow, she read the article and she said, I really want to see if we can collaborate. So we really started an organic collaboration based on Tiffany reading this article and reaching out to Cerise. And Cerise just happened to be meeting with CBHC and our tobacco team to talk about some strategies. So we had a meeting. It was a great meeting. Tiffany shared with us some of the videos they had made around quitting. She also shared this extensive survey that they utilized when they were intaking their smokers that were trying to quit. And we looked up and down and through it. It was really great. And we thought, we must have missed the menthol question. But then we went back to Tiffany and said, Tiffany, is the menthol in there? We just overlooked it. She said, my goodness, it's not on the survey, but we do ask our smokers all the time about that. So we thought, oh, it'd be great. Do you think you guys can add? And they're going to add the menthol question. They're going to answer that question for us. But we said it's been lost everywhere we're looking, it was like a gold mine or something. We just couldn't find it. So, but we did share the mission of connecting nicotine users to services, and particularly for us, culturally appropriate service where they would feel at home and they would trust that environment. So with that, I think I'm going to stop and pass it over to Tiffany so she can say what happened with this gold mine.
Thank you, Dr. Richardson. Move to the next slide. As was mentioned, we started this organic relationship with common goals of connecting patients to services, breaking down information silos. And so we really started this authentic community engagement. And what started as a relationship between our program and one other community organization just built off of there. And so every meeting we have, which we meet quarterly, we pull in other community groups with aligned goals of expanding services, breaking down information, not reinventing the wheel. If someone's already doing excellent work in a certain area, we want to build on that work rather than try to build new programs. And you can see some of our community partners here. There's many more that we're adding every single quarter, but we just don't want to duplicate work. There's plenty of work across the state for everyone, so we don't need to duplicate work. Next slide, please. As was mentioned, when I began this program, I built a flow sheet. And for those of you in the healthcare field who use Epic as an electronic medical record system, you know about flow sheets. For those who don't, it's basically a spreadsheet that is able to keep vast amounts of data. So when I started this program, no one across the UCHealth system was keeping track of data in a systematic way. Not for lack of trying, it's just really hard to get these things built within a large healthcare system. So we wanted to be able to keep track of information the same across the whole entire system. There's hundreds of thousands of rows of data at the end of a year, and we want to make sure that we're doing it consistently, keeping track of these bits of information consistently. So when we realized that we were not asking the menthol question, we were then able to go in and add this row. Certainly not going to go through all these questions, but For this topic, we were able to add menthol products, and this was added in June of 2022. And we're going to dive in. Aubrey's going to go ahead and dive into the results that we've collected since June of 2022. But we were able to work with physician builders and got buy-in from kind of key stakeholders on the design of this entire flow sheet. Normally, it takes months to get these rows added. We were able to get it added very quickly, which was a miracle in and of itself. But we do ask these questions at every visit of every patient, not just between Aubrey and I in primary care, but in oncology and in specialty clinics. So it is a way to ask everybody across the entire healthcare system. Next slide, please. And Aubrey, I'm going to hand it over to you to, oh no, sorry, this is still me. So this is just kind of some context of how many referrals our program gets. This is just in primary care. And this is in 2021, we work off of fiscal years. We're just completing our 2022 data sets. So this is broken down by race. And again, this is for Denver Metro. So we received almost 425 referrals, and this is the breakdown by race. Next slide, please. And this is the breakdown by payers. So we have a lot of private payers within UCHealth, therefore the data is a little bit skewed in favor of private payers. That is UCHealth's population. 22% of our patients are Medicaid versus 48% of African Americans who use the Colorado Quit line. So we know that more African Americans use the Colorado Quit line than what we see. So that number of menthol users is probably a little bit lower on our data sets than what the Quit line would see. Next slide, please. All right, Aubrey, if you want to take it over from here.
My turn. Thanks, Tiffany. So when we're looking at the menthol reporting across the UCHealth system, we're looking at referrals that were placed between May of 2022 to March of 2023. And so we have 982 unique patients that were referred to a tobacco cessation specialist. And when we look at the data collection for menthol, about 31% of those folks we've collected menthol data on. One thing to note here is we'll never get to 100%. Just because a patient is referred to a tobacco cessation specialist in our system doesn't mean they're going to enroll in that program or interact with them. But this is a really good starting point to know where we are at baseline in reporting for menthol use. Next slide. So I haven't broke it down in between our program and the rest of the tobacco cessation specialists across the system. So Ambulatory Nicotine Cessation program is actually collecting a little bit more on menthol use, at about 44%, and 14% of those are reporting that they are using menthol, versus about 25% of all other tobacco cessation specialists in our system. And like I said before, this is a really good starting point to know where we are in collection of menthol use. And we collaborate with all TTSs across the system. So this is really great shareable information. Next slide. We also did a demographic breakdown of menthol users across the system. And for the sake of time, although now it's not so much of an issue, I am looking at the two that had a statistically significant relationship with menthol, and that was age and race for our population. And if you see here, if you're 26 or younger, you're more likely to use menthol, or not more likely, you reported higher menthol use. Additionally, Black African American folks reported more menthol use. Next slide. So just, recap that information. And what we're finding clinically in our, tobacco cessation programs is very similar to what we find in the community, specifically the Denver Metro Black African American population. And like I said, this is a really great starting point for continuing to find outcomes between menthol users and non-menthol users. So I think, Tracy, it's on to you.
Okay, great. Thank you, Aubrey.
Mhm.
So next slide, please. So future data considerations. We do know that data, both quantitative and qualitative, helps to tell the story. And with that data, we have been able to start to identify opportunities to enhance and improve quit line policies, for example. We do have determined that there needs to be a longer consecutive coverage of nicotine replacement therapies for menthol tobacco nicotine users. Evidence does show that there are approximately 8,500 chemicals in a menthol cigarette, and we know that it takes longer to quit menthol flavored tobacco, especially for the Black smokers, who have higher quit attempt rates in comparison to other demographics. As also mentioned earlier, we found that it's very important as we continue to work with the quit line and they gather the data, they capture and share demographic outcome data to furtherance of telling that story. We've also identified Medicare coverage that we discovered that Medicare does not provide coverage for pharmacological products like Chantix and Wellbutrin and some NRTs. And to that point, then we recognize how important it is that no matter what age you are in quitting, when you do quit at any age, it is beneficial. We know that data shows that when a person quits smoking, their body begins to heal, that the heart rate and blood pressure drops after the first 20 minutes after quitting, for example, or blood circulation improves and lung function increases anywhere between 2 weeks to 3 months after quitting. So as time keeps passing on, the body continues to heal after quitting smoking or using tobacco. So again, it doesn't matter what age that you are, quitting at any age is beneficial. As mentioned earlier, the importance of culturally appropriate delivery of care. We found that it's very important to have a cultural focus and tailored cessation tobacco treatment resources and services in the quit journey, especially for our demographic of the Black African American tobacco nicotine user. We know that Black smokers face a number of obstacles to access and successfully use to smoking cessation services, and including the long-standing history in this country of mistrust of the medical and healthcare systems. We know that conventional cessation programs and individualized strategies are missing the mark when they do not address systemic and structural racism and socioeconomic injustices that have significantly contributed to tobacco-related inequities. And then finally, we are wanting to make sure that we're emphasizing the importance of encouraging other entities to collect robust menthol use data. We have found through our collaboration, for example, in our partnership with the CU Medicine Ambulatory Nicotine Cessation Program, Tiffany and Aubrey, has been very fruitful in starting that process of capturing menthol data usage from those who are seeking tobacco treatment services. And to that end, it is important to continue to work with and encourage other entities in the greater medical and health systems, as well as pharmacies, to collect, track, assess, and share that data so that we can continue to help tell the story. So with that, next slide, and we'll turn it back to Tiffany.
When we're looking at the downstream data impacts, we did address one area that we could have immediate impacts on, which was this Colorado statewide protocol for dispensing tobacco cessation products. And this was passed by Colorado legislation in 2018, and it essentially allows pharmacists who have taken this training to dispense all treatments for nicotine cessation. So in our discussions with our community collaboration, we identified a couple pharmacies within the Aurora area that we could train pharmacists within those pharmacies who are trusted by the community, who, families have been going to these pharmacies for years and years and years. They're trusted, and we could get these pharmacists trained. So we were able to obtain funding in order to get this training completed. We worked with the Colorado School of Pharmacy at CU, and pharmacists were able to get this training. So now members of the community, if they don't have a primary care physician, if for whatever reason they don't want to talk to their primary care physician about nicotine cessation, because there is a lot of shame associated with it, whether it's self-induced shame or shame put on them by their provider, they can obtain these medicines from their community pharmacists who they know and trust. And it was a great and kind of low hanging fruit that was easy to get taken care of. I think we got it done in 6 weeks. And now there are, Tracy and Terry, correct me if I'm wrong, I think there's 4 community pharmacists that have now been trained in 2 different Aurora pharmacies within the Black and African American communities, which is another way that we can reduce barriers to care and connect patients to immediate care, which is amazing. Next slide, please. So really, how are we using data to drive change? We're removing information silos. We identified an area where we didn't have any data. We knew the data existed, no one was collecting it. And so we were already set up in a way to collect data in an efficient way through the Epic EMR system. It automatically collects demographic data. So all we needed to do was add 1 row to a flow sheet. It was a very easy process to get that done. We want to depend on community experts to tell us what we need so that we can implement those changes and get them out. How can we move forward? We're already working within communities, so we're already doing the work. We have subject matter experts. How can we pump other resources in? Lung cancer screening. If we're talking to patients already, we already are building that rapport with patients, with communities. Can we also talk about things like lung cancer screening? Can we reduce the risk of patients dying from lung cancer, since we're already on the topic of cessation? Can we build a community pharmacy resource list? If we are getting these pharmacists trained and now patients have access to these resources, where do we direct them to go? How can we make sure that this list is up to date? And then how can we use data to leverage best practices and make sure everyone's on the same page with those best practices? So we want to make sure we make the best use of limited time and limited resources. Next slide, please. So in conclusion, I hope we've shown how strategic partnerships and data can support and impact upstream priority populations in real time to reduce health inequalities, such as access to tobacco cessation medications and counseling. And that's it. We'd love to field any questions.
Yeah, great. Thanks for that presentation. And I just want to commend you all on, finding a data gap and then working to fill it, and then actually using the data to provide services and resources to who needs them and who's going to benefit from them. So I think that's just such a great example of the full life cycle of what we want to do with data in communities. So, but yes, we are open for questions. Please feel free to put in the chat or unmute and ask any questions for this team about the presentation. Go ahead, Allison.
Oh, thanks. Yeah, I just want to echo Julia's congratulations on this research. It's just so cool to see a case study of a collaboration with communities to really look at issues that are important to community health. I guess I really liked your recommendation just about how like curriculum for tobacco cessation needs to be culturally appropriate. And I guess I'm just wondering if you could talk more if there's like a developed like curriculum that does like address some of the like areas or some like structural racism and like tobacco use and kind of like what that looks like, or if you have any like tips for people who are thinking about how to retool education and be sensitive to some of these like upstream causes.
Tracy, go ahead and say what we're doing.
Okay, because I also saw Tiffany come off mute as well too. So when it comes to you say curriculum, we're in the process and have been in the process of identifying what we call culturally focused cessation tobacco treatment resources for the Black African American community. We do recognize that there are multiple pieces like that do work in terms of counseling, in terms of the pharmacological aspect of it, as well as some self-directed help as well too. But we recognize for the Black community that some of the data that has come out, particularly where the quit line is concerned, where we got a number of people that start the quit line, but they not finish, with regards to getting to the cessation piece. So we're working through identifying those particular things that resonate, with our community and pulling that together and getting that out. Haven't really developed a comprehensive, if you will, curriculum per se. So that might be, I'll punt to Tiffany on that from the UCHealth perspective, but we do know that we are finding unorthodox ways. One example of that is auricular acupuncture, for example, that we've been working with another community related entities out there that offer that service, and to our Black smokers as a technique that they can use. So we're still compiling that information and more to come on that. Tiffany, did you have, or Aubrey or Terry?
Sure. From the UCHealth CU side of things, we have created some content videos, and in our writing of the scripts and things, we sought input from lots of different community groups and specialists. We also, all of the patients that we featured were obviously a very diverse group of patients from LGBTQI communities, very diverse ethnically group of patients as well. We've also been looking very heavily into the AI space. We are building algorithms as we speak. They have been built. We are beta testing them at the moment. UCHealth has a patient portal that utilizes AI called Livy, L-I-V-I, which is very similar to Siri or Alexa. And we are trying to figure out culturally appropriate algorithms for that, which is all very new technology, as I'm sure some of you are working with as well. And so that is more of a watch this space answer, but it's very exciting to be looking into those sorts of things. From a personal coaching treatment level, I use a lot of motivational interviewing to try to be culturally appropriate. Certainly when we're talking about menthol and I'm speaking with a Black patient, I use a lot of education of this is targeted. This is a very targeted ad campaign from the tobacco industry. A lot of patients have no idea the predatory marketing that the tobacco industry uses, and I do try to leverage that to make them mad because they should be mad, and it usually works quite well. So hopefully that answered your question.
I did want to interject as well too, because CBHC, we are focusing on the Black community, and that's what we've been working on over the last several years. So we actually have what we call a tobacco page, and that it has a wealth of information at our website, which is www.coloradoblackhealth.org. We have our tobacco page, we have fact sheets, we have the anatomy of menthol that goes through the history of how we got to this state as Black people. And we also, for some of the local public health entities and others who are interested, we have a toolkit that gives some general overview, some information on the cultural approaches in the Black community. So going to those two resources that we have right now, the idea of curriculum, we're trying not to reinvent the wheel, as Tiffany mentioned earlier. So we are looking to see what's out there before we develop anything that's super specific, because there could be something out there, but we do have those resources on our website.
And thank you, Terry, because I was about to round the bend. It's like, I forgot to mention menthol tobacco knockout page, but also on there, we do have some cessation tobacco treatment resources reflective of members of the Black community. So we do have a listing of what we have identified and researched and found to list there for members of the community and others to be able to tap into.
Great, thank you all for that info. We have a question in the chat from Dan Simon, just asking for some clarification around the stats around younger folks and the age differences in using menthol products.
Yeah, let me get to that question here. So Dan, great question. And I would like to say that there is definitely a data limitation in that we only had 8 people for that group. But to Tiffany's and everyone's point, with predatory marketing for big tobacco companies, we know that if you start smoking at a young age, you're more likely to continue smoking when you become older, and then all of those, health outcomes that happen. So looking at young folks in terms of menthol use is definitely a trend we want to keep an eye on, and remembering that this is our first go of looking at menthol collection for our TTSs, is with that in mind, knowing that there is that data limitation of having so few folks. Does that answer your question?
I would also say that you said yes, but I want to add too that we mentioned the younger age group, 40% of the Black smokers were in that younger age group. In general, Blacks tend to start smoking later, but 90% of all smokers usually start by the age of 18. So even though Blacks are starting later, and so in the stats that I was reporting was referencing the I can't remember the exact age, but it was I think I can't remember exactly, but anyway, that's just a point to make, that Blacks usually do tend to start later, so they don't start as early as other populations, but usually most have started by the age of 18, 90%.
And one thing also to note is that menthol can be in any tobacco product, not just cigarettes. It can be in electronic devices as well, which we do find that the younger folks are using. So.
Thank you. Any other questions, either in the chat or unmute? Okay.
Sorry, I just did want to interject that, this session was about collaborations and the partnership. And I think that as a community-based organization, we were just thrilled to be involved with an authentic collaboration. We get reached out to a lot of times for collaboration, but many times there's a lot of dissatisfaction because it's not really intended to be an authentic collaboration. But we can really say that Tiffany and Aubrey, it was a great example of authentic collaboration with a community-based organization. We really appreciate it, and the way that they reached out to engage others in this collaboration so that we can really serve the community. And it really was wonderful and beautiful to see. We don't see it often. So I want to give them a thanks during this time for their efforts in this collaboration.
That's great.
Thank you.
Thank you for, oh, go ahead, Tiffany.
Thank you very much.
I say thanks for
ways.
pointing that out, and to all of you for being, role models of how those relationships should work and can benefit community when they are done well. So, all right, well, we can wrap up then for today. Just a couple announcements before you head out. The slides from this session are on Sketch, so if you want to go back and look at them, you can find them there. After the conference is over, you will get a conference evaluation form via email. So we really request that you fill that out. Even if you only attend a portion of the conference, it's just really helpful for our planning committee to keep improving and make the conference better year over year. And there is a raffle for anyone who fills out the survey within the next 2 weeks. You could win one of 2 $50 gift cards. Next is a break in the schedule. Your break is a little bit longer since we only had one presentation. So feel free to go check out those walk and talk sessions. Those are audio only, like a podcast style presentation. So you can step away from the screen while you listen. There are two to choose from on the topic of community voice in health and environmental assessments. The next live session will begin in an hour at 2:45. and is another concurrent breakout. So you've got a few options to choose from, and you can check out the schedule on the Schedule website to determine which one you want to attend. So thank you again to our presenters, to everyone who attended and asked questions, and for joining us at the conference. See you all in some other sessions.
Thanks again. Bye.